helped physicians and caregivers think about the fact that empowering the patients to understand that yes, they are suffering from neurocognitive impairment really can make a difference in their lives. So it's a pleasure to welcome Dr. Armstrong back to Emory. You've been here a few times. Now, I am not, like Dr. Ekman, a wizard, but I think we've got you here. Right, Berger?
Thank you. When Chris sent me the email from Fadio asking me to join this conference, I said yes, and then I checked my calendar. Jim, it is just such a pleasure to be here. In 1985, I went to the University of Miami and walked into the pediatric hematology oncology area and was being recruited to come in and work with the leukemia and the brain tumor program. And there was a gentleman there named Chuck Pegalo, and he directed our sickle cell center. And as many of you knew Chuck, a delightful person but very imposing with that thick mustache, the very dour Minnesota style. And he glared across the desk at me and said, "If you think you're going to come here and just take care of these kids with bald heads with cancer, you've got another thing coming. If you want to walk in this door, you have to take care of at least one sickle cell patient for every 3 cancer patients you take on." And I said, "Just one?" And that formed a friendship with Chuck and my introduction into the world of sickle cell disease. And about a year later, Chuck said to me, "There's somebody you have to meet. There's this guy up at Emory named Jim Ekman. And I wanted, and Jim, I think you were in Minnesota terms walking on water in the summertime, but that was my introduction, because Chuck was also a Minnesotan. That was my introduction, and my work then was in the area of pain. And I got a chance to meet Jim Ekman, and in meeting Jim, the world sort of expanded. Because if there was one person who helped me as a new junior faculty member entering into a field that was far afield from what I trained to do, there was this person who said, "Look at the clinical concerns of these patients and think about them from birth to grave." And so as a person trained in pediatrics, all of a sudden my head started spinning about, well, how do I look at adults? And oh, by the way, what is all this stuff about pathophysiology and vasculopathy and things that I'd never learned in graduate school? And I was working on neurocognitive impairment. And so why was that important? It was school achievement, it's vocational choice, it's vocational success, it's relationships, it's aging. It really is the function that's the basis for what defines much of what we're able to do in life. It really isn't a set of scores on a test, and no one knew that better than Jim, and I thank you for bringing me to that perspective. So over 20 years, what have we learned about neurocognitive functioning in sickle cell? Well, we know that between 5 to 7% of children with SS will have a stroke before they're 15 years old. We know that between 22 to 35% will have a silent clinical infarct by adulthood. We know that children with SS without neurologic findings will have about a 1.5 drop in their IQ between the ages of 6 and 16 years of age. We know that indeterminate TCD flow rates that are associated with neurocognitive function in the executive functioning memory areas. We've learned recently that infants with sickle cell anemia have a declining trajectory of neurodevelopment over the first 3 years of life, and there is evidence that this poor behavioral regulation with each month of increasing age that starts as early as 7 months of age. And we've also learned that about a third of adults with sickle cell anemia who have no neurologic history, no pulmonary hypertension, the healthiest adults with sickle cell disease, I think, on the planet, who have a hemoglobin less than 10 grams, have a performance IQ of less than 85, and they're below average to lower. And we've learned something important, that neurocognitive function decreases with lower hemoglobin, even in the absence of evidence of neurologic injury and older age, an important component for Jim's work. So how did we get this started? I really look at it as serendipity. After meeting this incredible gentleman, I got an opportunity to write a paper with him in the Journal of Learning Disabilities. It was a summary on neurocognitive aspects of pediatric sickle cell disease. Kind of happened because Ron Brown, who was a good friend of mine, was working with Jim at the time and said, why don't we write this little paper, a special issue? And in that paper, we got to the last discussion section, and we talked about all the things that were going on. And Jim said, well, maybe we ought to add a couple of things. And so we added a statement. These impairments may be the result of cumulative microvascular infarcts, silent neurologic deficits secondary to anemia that are not detected on routine neurologic examination, ischemia or nutritional deficits, or single episode non-clinical infarcts. We were just kind of shooting the breeze trying to figure out what to put in that sentence, if you recall. That serendipitous conversation resulted in now this particular slide that shows many of the mechanisms that we're now linking to the potential for neurocognitive impairment in children and adults with sickle cell disease. We know vascular occlusion and structural ischemic damage because of stroke and SEIs. We know that there are issues related to stenosis and resulting ischemic injury at a microvascular level. We know the damage of repeated events. We've learned a lot about the role of chronic anemia and are still learning that, and we've certainly begun to understand the role of hypoxia. But poor cerebral oxygen perfusion, sleep disturbances, all of the mechanisms associated with hemolysis and nitric oxide availability and endothelial dysfunction, red cell adhesion, and the possibility that a lot of the things that we're looking at are related to chronic inflammation. And then over in the other areas, as we begin to map the genome, looking at relationships between different polymorphisms and sequences to some of the neurocognitive outcomes. Nutritional deficiencies are still grossly understudied. And of course, in this population, real concerns about social determinants of health and developmental outcomes, and emerging at the NHLBI, relationships between pain and neurocognitive dysfunction. Jim, we've come a long way since our sentence. When we began looking at neurocognitive outcomes in sickle cell disease, Chortikoff and Charlie Whitten in 1963 gave the whisk to a group of children with sickle cell disease and to their siblings, and found no evidence for cognitive impairment. And basically, that was the definitive study. Jensen came out with the arguments that blacks were intellectually inferior on the basis of race in IQ in 1967, and so that was the end point. We didn't do anything else in sickle cell disease, and we're not for about 20 years. And then in the 1980s and 90s, we began to say, well, actually, where did it come from? It came from parents who started to come in and see us and say, you know, my child is having problems here. And I don't think this is just because he's not working hard. And so we began to understand that there were specific functional deficits and developmental outcomes associated with this disease. And this is just a summary of some of the studies from the 80s and early 90s that found IQ differences between children with sickle cell anemia and comparison groups of different types. But when we began to look at specific functional deficits, you began to see them in areas of attention and visual motor ability and executive function, memory and processing speed, and problems across the areas of math and reading in school. And those the blue dots began to fill up the page. We then began to understand a little bit more about what was going on with young children. Bob Thompson and his group at Duke mapped out developmental decline on the Bailey scales in 0 to 3-year-olds. And then we just published in February this last year in Pediatrics the entry study from the Baby Hug. And what we found there, as I mentioned a minute ago, was with each increasing month of age at the time of study enrollment, the behavioral regulation score on the Bailey began to drop. It was about 2.8 points per month of increasing age. And we saw that was associated with increasing reticulocyte count. And we also saw it in some very specific functional areas, in the areas of communication, daily living, and socialization, but not motor abilities. And so that began to tell us that this process of neurocognitive delay was something that is likely happening very, very early on. It starts probably at birth. We started picking it up at 7 months of age. As part of our BTRP at the University of Miami, we've been doing a school-based intervention study, but we've also found and repeated some of the common findings that we're seeing in school-aged children. The most difficult is the ability to sustain attention, with problems in reading comprehension, recognition of words when they're reading, memory for auditory information, slow response time, task completion, and early and easy fatigue, and organization and planning. About a third to a half of the children that we're seeing have these particular kinds of problems. So where's the mechanisms? We know vascular occlusion, stroke, and SCI, microvascular disease come in. The CSSCD was really our big definitive study, enrolling about 800 children by newborn screening into this lifelong study. We stopped it at 20, but I'm still seeing my patients that were on the CSSCD. And what we found there was the real definitive breakdown, that children who had a normal MRI were functioning in the average range. If they had evidence of SCIs, they were functioning in the low normal to borderline range. And if they had evidence of a clinical infarct and MRI evidence, that these children were functioning in the borderline to impaired range. And there was a nice stair step based on what was happening in their brains. As we looked at the CSSD down the road, we sort of replicated at the end of the 10-year study the same kind of findings, but we had a surprising finding. There was a group of children who had normal MRIs, but they had significant declines in IQ. It was about 16 points, or about a point and a half per year over the 10 years that we followed them. MRIs were normal, and this was the graph that we had, the figure we had in Journal of Pediatrics. And that brought us back to that prescient question that Jim Eggman asked me: could chronic anemia be part of the process here? And that began to raise some real concerns for us. To flip ahead a little bit, working with another one of my very esteemed colleagues, Elliot Vashensky, and the team at Oakland Children's, we have just last year completed the adult neuropsychological function study with 149 adults with sickle cell anemia who were between 21 and 40 years of age. We had 40 matched healthy controls. These, as I mentioned, were the healthiest patients with sickle cell anemia, I think, on the planet. Our exclusion criteria were at least a page and ran over to the other. So we made sure that there was nothing else that could be going on that could be a problem. And we screened them for mood disorders and depression, for drug use and the like. And our primary criterion was a hemoglobin less than 10 grams. The outcome of that study, I think, caught all of us by surprise. In this high-functioning group of patients with sickle cell disease, a third, 33%, had the performance IQ on the Wechsler Adult Intelligence Scale less than 85, which put them in the below average range. The population rate for that is 16%, so it was double the population rate that was following this area, and these were significantly poorer than our matched controls for the study. But what we also found was that poor IQ was associated with lower hemoglobin and increasing age. And this was the graphic that we put together that looked at prediction models of what would happen for each 2-gram drop. And as you can see, if you had a hemoglobin of 12, you would have a slight decline, but it was in the normal range. Actually very close to the national average for American participants. If you got a 2-gram drop to 10 grams, we began to drop into the lower edge of the normal range. And if you got a drop to 8 grams, we began to fall even further. And so we began to see this very nice predictive link between drops in IQ and drops in hemoglobin. So the chronic anemia question that we saw in the children was actually holding up in this very healthy sample of adults. So where are we with that particular study? Just a couple of things. Using the free surfer program. It's an imaging analysis software. Where we did not find MRI abnormalities on gross T1 analysis in the adult study, as we've subjected that to reanalysis with FreeSurfer, we've identified subtle abnormalities in specific functional areas that are associated with processing speed, executive functioning, and memory. And that paper just got accepted in neurology, so you'll be seeing that in press. Another that we're looking at that also opened the door of what is going on from a mechanism perspective was that in addition to lower hemoglobin in this study, we also found that there were specific neurocognitive outcomes in the area of memory functioning, executive functioning, and the like that are also related to higher white count and higher platelet count. And so this is a multiple cell line hematologic problem, and that manuscript is under revision pending acceptance. And what we did with Elliot, and I sat down and said, well, if we're going to do this descriptive study, we ought to think about some treatment. And so we've done a pilot trial of chronic transfusion with very clear clinical benefits, fewer hospitalizations, less pain, the things that would not surprise us. It's not as clear for neurodevelopment. We weren't really powered for that. But I learned one very important thing from this study. One was that about 60% of the patients that we recruited for our adult neuropsych study had been the children I had followed for 16 years for the CSSCD. They were coming back to us as adults. They were doing well. That was a really positive component of this. But we had two of our patients who, during the study, and you imagine what we're doing, asking these parents to do, these patients to do. They're coming in and they have to miss work in the afternoon to get their type and cross. Then they have to come back the next day and sit for 3 to 4 units of transfused blood, and they're doing this about every 3 weeks. So it's a very big demand on an otherwise healthy individual. Two of our patients, one developed an antibody and one got pregnant in the middle of the study, and we had to withdraw them. It was one of the more difficult things that I ever did, and Jim, you'll appreciate this, because I brought these patients in. You would expect that telling them you don't have to do this anymore would be relief. I ran through 2 boxes of tissues as these patients sobbed about having to come off study. Not only because of their perceived benefits for them, but what they both said to me is, this was our chance to be part of something that could help other patients with sickle cell disease. And Jim, you've seen that. You've been a leader in helping us recognize that our research partnership is a partnership with our patients, and that we're not doing it to them, we're doing it with them. What we've known about vascular flow abnormalities is that children with transstate cranial Doppler detected flow rates greater than 200 centimeters per second, or a significant risk for silent or clinical infarction. Colleagues Ron Brown, again, when he was at Medical College of South Carolina, did the study and found that even those indeterminate rates were associated with slower processing speed, attention difficulties, and academic problems in the area of math. And so this is another mechanism for some of the difficulties. The exciting part that I'd like to wrap up today with is the baby hug trial, and this was our study to determine whether hydroxyurea was safe in terms of neurodevelopmental outcomes. Primary objectives were liver and spleen function, but also to determine whether hydroxyurea might provide protection against neurocognitive impairment in the early years of life. And this is relatively new information that's just been discussed and presented once. We're working on the paper. We had 193 infants and toddlers between the ages of 9 and 18 months at study entry. This was a double-blind, placebo-controlled, randomized clinical trial of hydroxyurea. Patients got randomized to a fixed dose of liquid HU or to a placebo over a 24-month period. This is the consort diagram for the study. At study entry, 15 of the 96 patients, or 15.6%, who were on hydroxyurea completed a baseline evaluation and had a mental developmental score in the below average range of 70 to 84, compared with only 10.3% on the placebo arm. At study exit at 24 months, 14 had scores in that below average range that was not significantly different from baseline, but 20 or 22.5% on the placebo arm fell between 70 and 84, and 5 of those had actually dropped below 70 into the impaired range. So the difference here was significant, and I think this bar graph will kind of show that for the patients on hydroxyurea, in the total sample, we had relatively stable numbers of stable neurocognitive neurodevelopmental function from entry to exit. But we wound up seeing the number of patients who fell into a delayed or impaired range more than double over that period of time. And so the suggestion here clearly is that HU may be serving a protective piece. So we then went on and looked at a subset of patients who had the mental developmental index less than 85 at entry, and also had a score of 85 on one of the scores at any of the 3 assessment points. So there's some variation that was going on there. This was a sample of 42 patients treated with HU and 54 with placebo. And what we found was that on the performance abilities, the non-mental, non-verbal, non-language-based things, there was really no significant difference in the pattern. They all improve at 12 months and then dropped at 24 months, both conditions. But when we looked at what happened in the groups that either had stable performance within a category class, improved or declined and then improved, and I'm really going to focus on the 2, you see that we had around 20% of both groups who had stable performance across all 3 assessment points. But when we looked at those who had improvement from baseline to entry, what we found was the HU group almost doubled the number. But what was also surprising to us, and I think very important as we deal with our mechanisms, is that the number of folks on the placebo arm who had declining function over that period of time was almost double the amount that was on the HU arm. And so this is really, we're working the data through here before we publish, but this is an exciting opportunity to suggest that hydroxyurea may actually be preventive for these young children, and for at least some subset, it may actually help to improve functioning over time, which is very exciting. The other piece with hydroxyurea that was important was with the MSH, and Jim was, I think, really instrumental in helping me to get engaged with that study as well, along with Abdullah and others here. We followed up the children who were the offspring of the adult patients who were treated with MSH, because one of our concerns was teratogenicity. And fortunately, I can say that when we followed these kids up, they were all functioning in the average range expected for their age with no detectable deficits. Thank you. We're very happy about that outcome. So what's next? There's a whole host of things that have that serendipitous 2-sentence paragraph in 1993 inspired me to do, and others in collaboration. We're looking at nitric oxide availability in infants, whether that nitric oxide is another critical pathway that has potential for intervention. We have a pilot study going right now looking at oxygen supplementation during sleep using CPAP. We're doing an innovative non-invasive imaging analysis of O2 perfusion and neurocognitive associations in children and adults. Looking at long-term use of hydroxyurea as part of the baby hug extension. Looking at the role of chronic transfusion to improve cognitive function in adults. And that ties into the last point. What about those patients who were not the most healthy? And if we had 33% who didn't have hypertension and didn't have neurocognitive problems and didn't have significant pain, what about the ones who do? And that's an area that we'll be focusing on in some of our future work. We're looking at how can we do advocacy for school access, and how do we translate that into support for adults? Because as we look at this, and also looking at some neurocognitive phenotypes and genome sequencing so we can better predict. We talk in cancer about individualized therapy. There is no better disease that I know that we could have if we could develop the kind of predictors to identify the specific risk factors for specific symptoms and develop targeted therapies for those individuals. And this is one of the places that has phenomenal opportunities. So as we've looked at things Jim is an adult hematologist working with adults with sickle cell disease with his foot promptly and firmly planted in pediatrics. Well, we do that for a good reason. One, for children, our best opportunities are the research that will help to prevent. And we can certainly do that with cure, with hematopoietic stem cell transplant, and Mark Walters is here. Mark, thank you for engaging me as a collaborator in the transplant world for many years, and that's curative. We have the opportunity to prevent in children by aggressively doing TCD and transfusing. We have the question, should we be thinking about asymptomatic children with low hemoglobin and getting their hemoglobins up to 7 through a transfusion plan? It's one thing that's on the table. What's the protective and preventive role and improving role of hydroxyurea? That needs to be further fleshed out. Are there benefits of sleep intervention to promote better oxygen perfusion and improve at least reduce risk of hypoxia and improve overall function from better oxygen saturation through oxygen supplement? Those are prevention strategies with children that can help us now. But what about the children and the adults that we haven't prevented? And this is where better roles and appropriate use of transfusion and the associated chelation is necessary. A more expanded role with hydroxyurea. How can we do it safely? How do we get better adherence and engagement and partnership with patients for being able to take hydroxyurea? Is there an aggressive role for anti-inflammatory medications? We've seen colleagues who have done the SMART trial looking at the use of aspirin, but there may be other options for us to think about. What about the behavioral cognitive remediation and school-based and vocational-based interventions, using assistive technology, text-to-speech, oral recognition, books on tape and the like for learning, and in both the academic environment and the workplace environment? Our patients, our children, the ones that I followed for most of my career, have grown up. They're now adults, and they come to me with the same kind of issues. A, how do I help my child do well? And B, can you help me in the workplace? I've got to have a job. I want to have a job. I want to be productive. And that's what part of this is really all about. My final consideration this morning is the cognitive impact of sickle cell may affect the choices, options, health, and well-being of patients throughout their lives. Understanding the problem and finding solutions has to be a priority for the next generations of patients and investigators, because patients want to know and they want to help so others can benefit. It's one of the joys of being in this world. And Jim, thank you from all your colleagues and your patients, yours here and the ones in Miami and Cincinnati and Baltimore and the Bronx. You've had a significant impact on all of us because of your vision of relating science to people. Thank you so much.